Hello everyone. Let's start the rapid revision of obstetrics and gynecology part 1. Question number 1. Which of the following is the most probable cause of bleeding per vaginum occurring 24 hours after the delivery? So bleeding after the delivery is a probable diagnosis for postpartum hemorrhage. Okay guys. So we already know the postpartum hemorrhage, if the bleeding is occurring within 24 hours, if it's occurring within 24 hours after the delivery, we call it as primary PPH. Okay, and if it occurs after 24 hours of delivery, we call it as secondary postpartum hemorrhage. Now the amount of blood that is lost during the normal vaginal delivery, if it exceeds 500 ml, and in case of cesarean section, if it exceeds 1000 ml. So guys, if we talk about the causes of PPH, if we talk about the causes of postpartum hemorrhage, the most common cause of postpartum hemorrhage is atonicity or an atonic uterus. What do I mean by this atonic uterus, guys? This means a large uterus. Large uterus, in which conditions we can have? For example, we can have in twin pregnancy. We can have in polyhydramnios when the amniotic fluid index exceeds 25. We can have in infections like chorioamnionitis. Okay, or in case of a gestational diabetes mother when the baby is more than 4 kg, or we can say when the baby is macrosomic. So in these conditions, we have a large uterus and we have more causes for the postpartum hemorrhage. The other cause that can be there is trauma. For example, some cervical lacerations can be there, tear can be there, vaginal lacerations can be there. So trauma is also a cause of postpartum hemorrhage. Then the next cause can be, guys, thrombin deficiency, thrombin related disorders. That, for example, we can have von Willebrand's disease, we can have idiopathic thrombocytic purpura, and we can have rarely hemophilias. Okay, guys, rarely hemophilias. Okay, now in our main classes, I've already integrated with a bit patho and medicine, guys. These hemophilias, we have A, B, and C. You just have to remember the factors that are deficient. Factor 8 is deficient in the hemophilia A. Factor 9 is deficient in the hemophilia B. And factor 11 is deficient in the hemophilia C. And inheritance, A and B are X-linked recessive, while as C is autosomal recessive. And B is known as Christmas disease. And B is known as Christmas disease. Just remember it in an integrated way, guys. Then after von Willebrand disease, we have a factor A deficient over there. And the fourth cause for this PPH can be, guys, tissue related. It can be tissue related, retained placenta beds. So these are all the 4 causes of postpartum hemorrhage. If I talk about atonic uterus, guys, it's the most common cause for primary PPH. What do I mean by primary PPH? Already discussed that it is the most common cause if the bleeding is within first 24 hours. But if the bleeding is after 24 hours, guys, then the most common cause is retained tissues. Most common cause after 24 hours of bleeding. Is that okay? So what was the question, guys? Which of the following is the most probable cause of the bleeding per vaginum occurring 24 hours after the delivery? So that is retained placental beds. The answer is retained placental beds. Okay. Now, guys, if I talk about a treatment, let me discuss a treatment here only. If I talk about the treatment of the PPH, the prophylactic drug that we use is oxytocin. The prophylactic drug that we use is oxytocin 5 to 10 units. And drug of choice is also oxytocin. How much, guys? 10 to 20 units. 10 to 20 units. The second drug after that we can use is methyl ergometrin. The second drug we can use is methyl ergometrin, having a peak action in 90 seconds. But you have to remember the contraindications of this methyl ergometrin, already discussed in our classes, guys. PIH, RH isoimmunizations, and heart disease are the main contraindications. Okay, then the third drug, we can start with the misoprostol, guys, prostaglandins, misoprostol. Then fourth drug, very potent drug in case of a treatment of a PPHs, guys. The drug is carboprost. The drug is carboprost. Okay, now the carboprost, the question related to this drug that have been asked multiple times in the NEET PG as well. What is the maximum dosage of this drug? Guys, if I talk about a dosage, it's 0.25 mg, and we can give this drug in maximum of 8 doses. Maximum of 8 doses, and that the maximum dosage you can give is 2 mg, and it's the only injectable drug that we give. Followed by that, we can use tamponades, Buckley's balloon, Foley's catheter. Okay, and after that we can go with the compression sutures. And remember one more question that they can ask from the surgical aspect, guys. What is the order of the arteries that are ligated in the PPH? Okay, we have uterine artery, followed by ovarian artery, followed by internal iliac artery. Internal iliac artery. Okay, guys, which branch of internal iliac artery? Anterior branch. Anterior branch of internal iliac artery. Okay, and if still the bleeding is not stopping, then the best among all you have to go for is hysterectomy. Then the best among all you have to go for hysterectomy. So guys, this was all about PPH, postpartum hemorrhage. Let's move to the question number 2. In PCOD, polycystic ovarian disease, the drug used for hirsutism and acne is metformin, OCPs with cyproterone acetate, bromocriptine, all of the above. Okay, guys. So let's discuss a PCOD, guys. Let's discuss a PCOD, polycystic ovarian disease. It's also called, guys, Stevens-Leventhal syndrome. It's also called Stevens-Leventhal syndrome. Okay. Now we have a criteria in this PCOD called as Rotterdam criteria. What is the name of the criteria, guys? Rotterdam criteria. In this Rotterdam criteria, out of 3, 2 should be present. What are these 3 things, guys? An ovulation. We have hyperandrogenism. And we have plus minus look on USG. And from the radiology, if I will ask you guys a question, guys, what is the appearance that we have? In case of an PCOD, a ring of pearl appearance. We have ring of pearl appearance. Never confuse it with the image of an ovarian hyperstimulation syndrome, guys. That is a different, and this PCOD image is different. Okay, now guys, one more thing. Let's discuss the treatment. If we talk about the treatment of hirsutism in PCOS, the treatment of hirsutism, guys, we start with the first line management and potassium sparing diuretic spironolactone. We also use anti-androgens because hyperandrogenism is the cause of this hirsutism and acne. So we'll start with the anti-androgens. We also start with finasteride as well as cyproterone acetate. So guys, this is a treatment of hirsutism. Okay. So what will be the answer for this condition, guys? OCPs with cyproterone acetate. OCPs with cyproterone acetate. Metformin, yes, metformin we use in PCOD when we have an insulin resistance over there. And bromocriptine is a drug used in hyperprolactinemia, along with cabergoline. You already have studied in your pharmacology, guys. Along with cabergoline. Now, the drug that we use for ovulation induction. If the question mentions what is the drug of choice for ovulation induction in case of a PCOD, okay, for ovulation induction. For ovulation induction, we use a drug called letrozole. But if question mentions drug of choice of ovulation induction, not in PCOD generally, then we have clomiphene citrate. One more thing, that the cutaneous mark due to this insulin resistance, we call it as acanthosis nigricans. We also seen in where, guys? PCOD. Acanthosis nigricans in case of PCOD. You have remembered, you have studied from your main note, guys, Sheehan syndrome. Okay. HA for hyperandrogenism. IR for insulin resistance. And AN for acanthosis nigricans. Is that clear to you guys? Okay. And the surgical treatment that we have in here, if I talk about the surgical treatment here, we have ovarian drilling. We go for the ovarian drilling so that the stroma will be thin and they will get enough glucose and will have a normal cycle. Ovarian drilling. Okay. Anything else, guys? Yes. One more objective that they can ask. What is the reason of the bleeding in case of PCOD, guys? You have already discussed. PCOD mein kya hota hai? Ischemic withdrawal. There is an ischemic withdrawal. But in the normal cycles, which withdrawal we have? Progesterone withdrawal. So guys, I've discussed all the PCOD here, all the important things. So main things you have to remember, guys: Rotterdam criteria, the treatment for this hirsutism. We also later on, to decrease this depression levels, we go for the cosmetic treatment. Then the drugs that we use for ovulation induction. Along with that, guys, ovarian surgical drilling. And last, the ischemic withdrawal in PCOD. And remember this picture, ring of pearl appearance, guys. Go through the pictures. That's it, all about PCOD. So let's start with another question, guys. A 30-year-old woman who presented with secondary dysmenorrhea has been diagnosed with endometriosis. Which of the following drugs is not useful in treating his patient? Which of the following drugs is not useful treating this patient? Guys, if we talk about endometriosis, what is the cause of endometriosis, guys? The cause of endometriosis, guys, it occurs due to the retrograde menstruation. It occurs due to retrograde. It occurs due to retrograde menstruation. What do I mean by retrograde menstruation, guys? Backflow of the menses. But now the patient having good immunity, they don't develop this endometriosis, and the patient having a weak immunity, they get this endometriosis. So the classical symptoms of this endometriosis, how this patient will present to you, guys, you have to always look for these classical symptoms: dysmenorrhea, dyspareunia, that means a painful intercourse, and rarely infertility, guys. Infertility. Okay, rarely infertility. Okay, if I talk about the age group is 3rd to 4th decade. The age group is 3rd and 4th decade. The age group is 3rd to 4th decade. If I talk about the most common site, for this endometriosis, the most common site for endometriosis is ovary. The most common site for endometriosis is ovary. And the second most common site is pouch of Douglas. The second most common site is pouch of Douglas. Remember these things. On pathology, if I'll mention, guys, we have a powdered burn lesions. And along with that, we have a cyst called chocolate cyst. Guys, last MCI question was, what is if there is a cyst, a recurrent cyst in case of endometriosis, what is the treatment? Cystectomy. What is the treatment, guys? Cystectomy. Okay, guys, cystectomy. Now, guys, let's discuss the treatment of endometriosis, guys. In endometriosis, we have hyperestrogenic state. We already know that estrogen, if we talk about normal cycle, guys, we have discussed in our main classes as well. As this is a rapid revision session, that's why I'm going a bit faster. Okay, just grab the ideas, whatever we are discussing. Okay, so if we talk about the normal cycles in the first 14 days, guys, proliferative phase, which hormone helps, guys? Estrogen. Estrogen is responsible for the proliferation of the endometrium. Estrogen is responsible for the proliferation of endometrium. That is why endometrium is proliferated. And in case of an endometriosis, what is there? There is an hyperestrogenic state. That means there is more estrogen. Okay, so what will be the treatment? The treatment will be anti-estrogenic drugs. Yes, that is why the anti-estrogenic drug that we use is danazol. The anti-estrogen drug that we use here is danazol. What is the main purpose of danazol, guys? Atrophy of endometrium. It will do the atrophy of endometrium. But the side effects of this danazol is virilization. The side effect of this danazol is virilization. What do I mean by this virilization, guys? There can be the breast atrophy, there will be clitomegaly and hoarseness of the voice. And once the patient is complaining of hoarseness of voice, you have to stop this drug. Simple. We also use injection depot medroxyprogesterone acetate, injection DMPA. Okay, 150 mg once in 3 months. Okay, injection DMPA once in 3 months. Okay, depot medroxyprogesterone acetate. Okay, so these are the two main drugs that we use in case of a PCOD. Rest, we also use GnRH analogs, OCPs, but the mainstay of the treatment will be danazol and DMPA. So the lady coming to you with the complaints of dysmenorrhea, dyspareunia, on pathology you have a chocolate cyst, and on investigation you have powdered burn lesions. The classical diagnosis is endometriosis. So the question was asking, guys, which of the following drug is not useful in the treat this patient? So estrogen is the answer. Okay, as I've mentioned already, DMPA we give, guys, danazol anti-estrogen, that causes the vascular we give as a treatment. Okay, and GnRH analogs as well. So estrogen cannot be used as a treatment in endometriosis. Clear, guys? Let's move to the next question. One more point, guys, I will discuss here only. That will be useful for you guys. For endometrial cancer, if a classical case of endometrial cancer will come, number one thing, guys, endometriosis will never cause an endometrial cancer. Okay, endometrial cancer, the peculiar finding, the presentation of the patient will be, he will be obese, it will be hypertensive. Okay, and most of the times it will be post-menopausal bleeding. Post-menopausal bleeding. So endometrial cancer, obese patient, hypertensive, and post-menopausal bleeding. That is endometrial cancer. Post-coital bleeding mainly towards the cervical cancer due to HPV 16 and 18, moreover HPV 16. Next question, guys. Which of the following is included in the active management? Which of the following is not included in the active management of the third stage of the labor to prevent postpartum hemorrhage? To prevent the postpartum hemorrhage. Okay, so guys, if we talk about an active management of third stage of labor, that is called as AMTSL. So we already know, guys, how many stages of labor we have. We have 4 stages of labor. Okay, stage 1, from contraction to the dilatation, then from dilatation to the delivery of the baby, then from delivery of the baby to the delivery of the placenta, and then the observation. Now this third stage of the labor is so important because if anything if anything is not handled properly in this stage, complications can occur. For example, what can be the complications, students? The complications can be uterine inversion can occur. Okay, shock, patient can go into the shock. Okay, postpartum hemorrhage can occur. Okay, and this delivery of the placenta is the main factor over there. Okay, so for example, if the doctor, if a staff member is pulling the placenta forcefully, what will happen? There will be the uterine inversion. Okay, guys, there will be a uterine inversion. So in order to decrease these complications, we have active management of third stage of labor. Okay, this third stage of labor, usually it's 10 to 15 minutes. Okay, but if it exceeds more than 30 minutes, we call it as prolonged third stage of labor. We call it as prolonged third stage of labor. Okay, then, guys, we have, as per this active management of third stage of labor, guys, we have 4 steps. Step 1, guys, administer the uterotonic agent. Administer the uterotonic agent. Step number 2, delayed cord clamping. Step number 3, guys, delivery of the placenta. Brand and Andrews method, and step number 4, assessment of uterine tone. These are the 4 steps, guys. Now, how placenta is delivered, we'll have a coming questions. I will teach over there. What are the ways we'll deliver the placenta? Okay, what are the ways of separation of this placenta? What are the different types of adherent placentas in Creta, Ecreta, and Parcreta? But here, guys, what was the question? Out of the following, which is not included, guys? If I talk about this administer of the uterotonic agent, the uterotonic agents that we use are the 2 drugs mainly, oxytocin and ergometrin or methyl ergometrin. Oxytocin or methergin. Okay, so here the option number C is injection carbopros. No, injection carbopros we use in the case of a treatment of postpartum hemorrhage. That's already discussed in the first question. Okay, so what are the uterotonic agents we use? Oxytocin and methergin. Yes, uterotonic within 1 minute of delivery. Yes, delayed cord clamping already discussed, and control cord traction. That is what the method for delivery of the placenta. Before we used to have one method of delivering the placenta called as Creed's method. Okay, but that Creed's method is absolute now. Okay, Creed's method is absolute now. Why it's absolute? Because it causes the secondary PPH. Okay, it causes secondary PPH. That means there are retained placental bits after this Creed's method, and once the patient is having this retained placenta bits, you have to go for curettage, guys. What will be the mainstay of the treatment? Curettage. And after this curettage, the complication that the patient will have after the curettage, the complication the patient will have is called as Asherman syndrome. Now, examiner can play with you. He can mention uterine synechiae. Okay. So in case of an abortion, when the patient is going for curettage, in case of an choriocarcinoma, we have to go for curettage. In case of sometimes the ectopic pregnancy. So all these conditions where you are going for curettage, the complication that can occur is Asherman syndrome. Patient will complaining of the secondary amenorrhea. Is that clear, guys? Or the another name for this is uterine synechiae. So that's why this Creed's method was absolute. The next question, guys, which of the following complications is unlikely in a patient with a gestational diabetes? Okay, guys. So let's discuss the options: abortion, macrosomia, postpartum hemorrhage, oligohydramnios. So let's start with the discussion of gestational diabetes, GDM. Okay, gestational diabetes mellitus. Okay, first of all, guys, it occurs after how many weeks? 24 weeks. You have to remember, GDM occurs, gestational diabetes occurs more than 24 weeks. If the patient is already having a diabetes, we call that overt diabetes. Okay, we call that overt diabetes mellitus. Is that clear? Now, this GDM, it's because of the two hormones, HPL, human placental lactogen, and estrogen, because they have insulin-like action and causing insulin resistance. So what two hormones are responsible, guys? HPL and estrogen. Okay, and complications are moreover, guys, complications are associated with the over diabetes mellitus. But with the GDM, what can be the complications, guys? Let's write what can be the complications. The complications that can occur is shoulder dystocia due to the large baby. Shoulder dystocia can happen. Okay. And what is the manure for shoulder dystocia? Remember, Mac Roberts manure. Number second, guys, obstetric injuries can happen as the baby is macrosomic more than 4 kg. So the obstetric injuries are more, that means more cases of PPH. Okay, so these are the complications of this GDM, guys. One question, guys, that they can ask, out of which are all the followings which is not seen in what? Baby of a gestational diabetic mother. Okay, in case of an infant of the GDM mother, he will be hypoglycemic. There will be a hypoglycemia in baby. Okay, mother is hyperglycemic, but the baby will be hypoglycemic. Why? Due to the hyperplasia of the beta cells of the pancreas. The only reason why baby is hypoglycemic, guys, due to the reason that there is a hyperplasia of the beta cells of pancreas. Insulin is coming from there only. Okay, if I talk about drug of choice, guys, drug of choice is insulin regular. And if I talk about oral drugs that we use, it's metformin. Guys, metformin with the class biguanides. And another drug, it's glyburide. It's sulfonyl urease. What is the side effect of metformin, guys? From the pharma point of view, lactic acidosis, and for the glyburide, it is hypoglycemia, sulfonyl urease. Okay, guys, this was all about gestational diabetes mellitus. And the causes out of the following, guys, unlikely to be seen. Polyhydramnios is associated. Polyhydramnios is associated with the gestational diabetes mellitus, not the oligohydramnios. And the test that we do is a one-step test. Let me discuss. MCQ can come from this. The test that we do is a one-step test. What is this one-step test, guys? We give 75 grams of glucose. Okay, then check the reading, guys. If it's less than 180 in 1 hour, it's normal, or less than 153 in 2 hours, I call it as normal. So it's all about gestational diabetes. So out of the following options, guys, yes, gestational diabetes, abortion can happen, macrosomic baby is there, due to the increase in sign, postpartum hemorrhage, due to the atonic uterus can happen, but oligohydramnios is not seen in GDM. Okay, guys, what is seen in GDM, guys? Polyhydramnios. If I talk about this oligohydramnios also, let me discuss a bit oligohydramnios. If I talk about this oligohydramnios, guys, it's a decreased amniotic fluid. That means AFI is less than 5. Amniotic fluid index of less than 5. And remember, most common cause of oligohydramnios is bilateral renal agenesis. Bilateral renal agenesis. And this amniotic fluid after 20 weeks, the most common constituent is fetal urine. And if the patient is taking drugs like ACE inhibitors or NSAIDs, that will decrease the urine output and further will have less amniotic fluid. Maximum amniotic fluid is 32 to 34 weeks. Yes, some books write 34 to 36. So you can take the mean 34, 35 weeks. That's it. Next question, guys. A multigravida who had a normal vaginal delivery. A multigravida who have a normal vaginal delivery develops postpartum hemorrhage. The third stage was managed actively and placenta and membranes were expelled completely. What is the first step in the management? What is the first step in the management, guys? Okay, so let's discuss the treatment, guys. One by one, guys. Let's discuss the treatment. Treatment of PPH. We have already discussed. Let's discuss this fast. Okay, first of all, guys, prophylactic drug you always start is oxytocin. Remember, step by step, 5 to 10 units. Okay, then drug of choice is also oxytocin, 10 to 20 international units, guys, in a drip form. Okay, drip se dena hai. Never give IV, never give bolus. Yes, right, never give bolus. Why? Because it can cause sudden hypotension. Because it can cause sudden hypotension. Then the second, guys, you will start with the methergin, methyl ergometrin, then misoprostol, then carboprost. Then we can use fresh frozen plasma as well. Okay, fresh frozen plasma as well. Then we can use balloon tamponades. We can use balloon tamponades such as Bakri balloon, such as Foley's catheter. And in India, we can use the cheapest condoms. Okay, Bakri balloon have a capacity of 500 ml of NS, guys, and Foley's catheter have 150 ml. Okay, balloon tamponades. Then we can use a compression sutures, my dear students. Compression sutures, brace and Heyman sutures. Brace and Heyman sutures. Then artery ligations will go with the uterine artery, ovarian artery, internal iliac artery. Which branch, guys? Anterior branch. If you will ligate the posterior branch, what will happen, guys? That go down to the lower limbs and there will be a paralysis of the lower limbs, guys. Okay, so that is all about the treatment. And methergin, you have to remember, I'm writing here the contraindications are important that I have already discussed. Heart disease, pregnancy-induced hypertension, RH isoimmunization. Okay, so guys, first of all, the first step always will be, guys, you have to resuscitate the patient, insert 2 14-gauge cannulas and start IV fluids. Okay, guys, so let's discuss these cannulas. We've already discussed in our anesthesia as well, guys. So 14-gauge cannulas. Okay, so let's remember the color coding. Orange is 14. Okay, gray is 16. Green is 18. Pink is 20. Blue is 22. Yellow is 24. And violet is 26. Okay, so this was all about cannulas. So the first step always is, guys, what you have to resuscitate the patient. So insert 2 14-gauge cannulas and start IV fluids because the patient can go into the shock. And I've already discussed bleeding after the delivery. Patient goes into the shock. The probable diagnosis is postpartum hemorrhage. If the patient is going immediately into the shock, your diagnosis is uterine inversion. Okay, if the question mentions immediately into the shock, your answer should be uterine inversion. But if the question mentions patient goes into the shock, then it's what? Postpartum hemorrhage. And if the patient goes into the unexplained shock, then with the complaints of hypoxia, hypotension, and coagulopathy, then the diagnosis will be amniotic fluid embolism. Then the answer will be amniotic fluid embolism. Okay, amniotic fluid embolism. Hope you'll understand this handwriting, guys. I'm writing fast. Okay, amniotic fluid embolism. Guys, let's move to the next question. Clear with this one? Okay. A 26-year-old primary gravida at 30 weeks of gestation came for a regular antenatal checkup. On examination, the uterus corresponds to 34 weeks of gestation with a normal fetal heart rate. The TVS revealed the AFI of 26. The TVS revealed AFI of 26. Which of the following is condition most likely to be associated with this patient, guys? So what is your probable diagnosis? Okay, guys, the AFI of 26, more than 25 is polyhydramnios. It's polyhydramnios. So let's differentiate these two, guys. Let's differentiate these two, oligo and polyhydramnios. First, we'll write oligohydramnios. Then the second, we'll write polyhydramnios. Polyhydramnios. In case of oligohydramnios, guys, AFI is less than 5 centimeter. Here AFI is more than 25 centimeter. If I talk about the causes, the only question that from the amniotic fluid dynamics, from the amniotic fluid chapter that they can ask is the causes and AFI. Are you getting my point, guys? Out of which of the following is from oligohydramnios, except out of which of the following causes is from polyhydramnios, except. So you have to focus on the causes mainly, guys. The bilateral renal agenesis is the most common cause for oligohydramnios. Bilateral renal agenesis. There can be the obstruction, guys, posterior urethral valve. Okay, once there is an obstruction, guys, less urine will come, and I've already told you guys the fetal urine is a more common and most constituent of the amniotic fluid. Once there will be a less fetal urine, eventually what will happen? There will be decreased amniotic fluid. Post-term pregnancy, that means 42 weeks onwards. Okay, 40 weeks onwards, 42 weeks onwards, we'll have a decreased amniotic fluid. At peak, it will be around 35, 36 weeks. After that, amniotic fluid start decreasing, and it's said to be 600 ml during this 39, 40 weeks. And eventually it keeps decreasing. So oligohydramnios will be also seen in post-term pregnancy. And if the patient is taking NSAIDs or ACE inhibitors, from the pharma point of view, guys, you already know indomethacin decrease the urine output, and that is an NSAID. Also, ACE inhibitors, what is the side effect, guys? Two side effects that you remember from the pharmacology point of view. The two side effects are bilateral renal stenosis and angioedema in case of ACE inhibitors. So that is why they can also cause oligohydramnios. Okay, and also intrauterine growth restriction. We can see what? We can see oligohydramnios. The treatment is, guys, just increase the surveillance of the baby and try to push the pregnancy more than 30 to 34 weeks so that the fetal lungs are matured and you can deliver the baby. Then, guys, in case of a polyhydramnios, the cause is, most common cause is idiopathic. Looks right, it most common causes idiopathic, but you will remember the other causes. Okay, the other causes, for example, the first one is twin pregnancy. Twin pregnancy will have increased amniotic fluid. One other cause that we already solved the question before, gestational diabetes mellitus. Okay, guys, esophageal atresia. Okay, cleft palate, gastrochisis. Okay, how do you differentiate gastrochisis with the omphalocele? There is a sac covered in case of an omphalocele, and in gastrochisis the structures are open coming out. Okay, so these are all the causes. There's cleft lip, guys, cleft palate. It is also caused by the retinoic acid. If the mother is taking vitamin A in the pregnancy or an methotrexate, guys, what will happen? Cleft palate is a side effect. And what is the treatment for polyhydramnios, guys? If I discuss the treatment of polyhydramnios, you give NSAIDs. Okay, guys, you give NSAIDs, you give ACE inhibitors. Okay, later on you give ACE inhibitors after the organogenesis, no problem. Before, it's contraindicated. I know the hypertensive drug of choice is you have labetalol followed by alpha-methyl dopa with the nifedipine, prazosin, and hydralazine. Okay, but after 20 weeks, after the organogenesis has already been there, okay, after 30 weeks, later stage, you can give ACE inhibitors, and NSAIDs are also be given. So that will decrease the amniotic, that will decrease the urine output. So the amniotic fluid will be decreased and polyhydramnios will be treated. Also, you can go for the therapeutic amniocentesis. Therapeutic amniocentesis. Is that clear, guys? So that is all about oligohydramnios and polyhydramnios. Then we have a different color of amniotic fluid in different conditions. For example, if you have a green color, you have meconium stained. If you have a red color, you have antepartum hemorrhage. Mainly in a red amniotic fluid. Red amniotic fluid is mainly associated with the antepartum hemorrhage. But which antepartum hemorrhage mainly? Abruptio placentae. You have yellow color in case of an RH incompatibility. You have straw color in a normal or a post-dated pregnancy. Is that okay? So that is based on the color. Rest, all the causes I've discussed, treatment I've discussed, this is all. So which of the following condition is most likely to be associated with the patient, guys? So out of these conditions, the only condition that will be in a favor of a polyhydramniosis, cleft palate. Renal agenesis, NSAIDs, and posterior valve are the causes of oligohydramnios when the amniotic fluid index is less than 5 centimeter. If there is no amniotic fluid at all, we call it as anhydramnios. The branches of anterior division of internal iliac artery include the following, except. So guys, PPH question again coming. So the branch of anterior division, this you already know, guys. These arteries are ligated. These arteries are ligated in case of PPH, in case of postpartum hemorrhage. Okay. So which artery? Mainly anterior internal iliac artery. Which artery mainly, guys? Anterior internal iliac artery. So guys, you have to remember the branch. You have to remember the branch of posterior internal iliac artery. Remember the posterior one because we have only 3 branches. So that except those 3 branches, guys, you already know the rest are what? Anterior branch. You remember it with the mnemonic short gills. Short gills. SG for superior gluteal. SG for superior gluteal. IL for iliolumbar. And LS for lateral sacral. So these are the 3 branches of posterior one. Okay, guys, and rest are anterior. So all of these are anterior division branch except superior gluteal. Superior gluteal is a posterior branch. And if you ligate this posterior, what will be the complication, guys? If you ligate the posterior, the woman will complain after the PPH, after the artery ligation. She will complain, doctor, I am feeling a bit paralytic limbs, lower limb paralysis. She is not able to walk and have constant pain. She's feeling numbness. So that is due to what, guys? The doctor has ligated or misidentification of the ligation of the artery. Rather than ligating the anterior branch, he has ligated the posterior branch. So it is an anatomical question, guys, more towards from the anatomy, but yes, they can ask the integrated way. A 20-year-old Gravida 3 para 1 abortion 1 at 33 weeks of gestation came to the OB-GYNAE clinic for a regular antenatal checkup. She's a known case of preeclampsia diagnosed at 26 weeks. Now her blood pressure is 130/90 and non-stress test is reactive. What is the plan of management in this patient? Simple question, guys. Let's look out the main hints and the findings and we can easily grab this question. Okay, so don't rush in such questions. The more important part, once you are solving a OB-GYN question, OB-GYN is a scoring subject, guys. I'm already seeing in the main classes as well. So what you focus is here is the gestational age and the present condition, and always see is patient in the labor or not. So most of the people, what you mark is directly whenever you see LSCS, you feel okay, LSCS is easy. Yes. Okay, guys. So as an obstetrician, tomorrow, if you'll be an obstetrician or a gynecologist, patient will come to you for a normal antenatal checkup, guys. It's not that you will directly tell her, okay, lie on the bed and go for LSCS. So question is saying she is just coming for the main point, antenatal checkup. So you cannot directly go for, first of all, immediate LSCS. And she is a preterm, okay, 33 weeks. Another hint, she was diagnosed as preeclampsia. She had a pre-eclampsia, but at how many weeks? 20 weeks. But now presently her BP is normal. So what will be the plan of management? The plan of management will be, guys, wait till 37 weeks of termination. You have to wait unless you will get into the term, because we don't have any condition right now. You will give magnesium sulfate, you'll give dexamethasone and endeus, and you'll plan for LSCS. Now let's discuss these options one by one, guys. This magnesium sulfate you give in case of an eclampsia. Okay, give dexamethasone when the baby is in fetal distress, guys. Yes, we can plan, guys, giving first dexamethasone and betamethasone for the fetal lung maturity. For the fetal lung maturity. So there is no condition, guys, that you will induce it and get the baby. And LSCS at this point you cannot go. Baby is normally no fetal distress, everything is normal, her blood pressure is normal, her NST is reactive, she's just coming for an antenatal checkup. So the answer will be you have to wait till 37 weeks of termination. So let's discuss this eclampsia, pre-eclampsia, guys, one by one. So first of all, guys, gestational hypertension. What do I mean by this gestational hypertension, my dear students? Gestational hypertension, remember always, it occurs more than 20 weeks onwards. Kab hota hai, guys? More than 20 weeks. Okay. When the blood pressure is more than 140/90, when the blood pressure is more than 140/90, on two occasions, 6 hours apart, on 2 occasions, 6 hours apart, in a previously normotensive woman, at that time we can call it as a gestational hypertension. At that time we can call it as a gestational hypertension. Okay, gestational hypertension. Then, guys, what is pre-eclampsia? What is pre-eclampsia? It is blood pressure more than 140/90, more than 140/90, plus proteinuria. How much proteinuria? Plus 1 urine dipstick. Plus 1 urine dipstick. Now some books write also 300 mg per 24-hour urine. So both are correct, guys. Okay. So when we have a blood pressure more than 140/90 plus proteinuria, we call it as pre-eclampsia. Okay. And if we have pre-eclampsia, plus convulsions, now the patient is having convulsions, we call it as eclampsia. We call it as eclampsia. Guys, for this eclampsia, the drug of choice is magnesium sulfate. Okay, how much to give, guys? 4 to 7 milli equivalent. Okay, more than that there will be the toxicity. The question PYQ that was discussed, the first sign will be loss of deep tendon reflexes. Okay, the first, when it exceeds. And the antidote, you already know what is the antidote for magnesium sulfate, guys. Calcium gluconate. We give it the two regimes called as Pritchard's regime and Zosparm regime. So it was all about eclampsia, pre-eclampsia. Okay, now this convulsions, guys, what happens? This PIH, it is associated with the oligohydramnios. Why, guys? Once there is a severe eclampsia, guys, there is a less blood flow to the brain. Okay, and when there is a less blood flow to the brain, it causes cerebral edema, further causes the convulsions. And same, when there is a less blood supply to the kidneys, what will happen? There will be a decreased GFR, and once there is a decreased GFR, there is decreased fetal urine. Once there is a decreased fetal urine, there is decreased amniotic fluid, and decreased amniotic fluid is called oligohydramnios. So, guys, I've already discussed. Again, just giving you an idea, guys, how these conditions predispose to convulsions and as well as to oligohydramnios, because there is a less blood supply to the kidneys, decreased GFR, and decreased amniotic fluid. If we talk about a pathophysiology of this, if we talk about the pathophysiology of this PIH, guys, how this actually occurs, it is due to the incomplete trophoblastic invasion. It's due to the incomplete trophoblastic invasion. Okay, once there is this trophoblastic invasion, these high resistant vessels are replaced with the low resistant vessels. Okay, but when they are not replaced, that means when there is an incomplete trophoblastic invasion, the resistance of these vessels remains high and causing the pregnancy induced hypertension. Or in a one word you can mention, guys, vasospasm. There is continuously vasospasm over there. That's why PIH occurs. That is why drugs like furosemide or ACE inhibitors are contraindicated, because they will further cause vasospasm. Now the blood pressure can go higher and higher, causing the death of the infant or the baby. Is that okay, guys? Death of the baby. Is that okay? So that's the pathophysiology. One word you have to remember: incomplete trophoblastic invasion and vasospasm. Okay, drug of choice I've already discussed. Definitions you have to mainly remember, guys: proteinuria in preeclampsia, proteinuria plus convulsions in eclampsia, and main criteria, guys. They can mention out of which of the following is correct: more than 20 weeks. 20 weeks you have to remember, 20 weeks, and more than 24 weeks in the GDM. Let's move to the next question, guys. A woman presents to the OPD. A woman presents to the OPD with the complaints of amenorrhea for the past 2 years. She has a history of the postpartum hemorrhage and the lactation failure. She complains of appearance of vitiligo-like white patches. Also, what is the probable diagnosis? What is the probable diagnosis, guys? Now, guys, what happens once the patient is delivering and she's a case of a postpartum hemorrhage? Once there is a lot of bleeding, okay, this lot of bleeding causes the necrosis in the post pituitary, okay, guys, posterior pituitary necrosis, or we can call hypopituitarism. And once there is a necrosis of the posterior pituitary, or once there is a hypopituitarism, what happens? Patient, all the hormones LH and FSH are coming from pituitary only, guys. Now what happens when there are decreased these hormones? There will be no estrogen and progesterone, no estrogen, progesterone, no proliferative and secretory endometrium, so no menses. So patient is directly landing into the amenorrhea. So guys, when the patient is, along with that, the first symptom of that is lactation failure. So your probable diagnosis here is Sheehan syndrome. Your probable diagnosis here is Sheehan syndrome. Okay, guys, this Asherman syndrome, guys, I've already discussed with you guys how the patient will complain after the curettage. Okay, uterine synechitis. Steam and Leviathan syndrome is nothing, guys. It's just PCOD, already discussed. Severe syndrome is 46XY. That we'll discuss in further questions when we'll discuss about the Turner syndrome or the Klinefelter's syndrome. Okay, so Sheehan syndrome, guys, it's suspected in those, mainly write it down. It's suspected in those. It's suspected in those who had PPH after the delivery. Who had PPH after delivery, because once the whole blood will be lost, there is hypopituitarism, guys. Okay, so the presentation of the Sheehan syndrome, how this patient will come, guys. The presentation, there will be failure of lactation. Simple one-liner. What is the first symptom of the Sheehan syndrome? Lactation failure. Prolactin ही नहीं आ रहा है, guys. Lactation failure. Failure of lactation. Failure of lactation, that means prolactin deficiency. Prolactin deficiency and amenorrhea, absent menstruation. Amenorrhea. Okay, there are the features of hypopituitarism. Okay, there are features of hypopituitarism and post-pituitary necrosis. Post-pituitary necrosis. In options, they can mention another name. You might have solved that PYQ. Pituitary apoplexy. Pituitary apoplexy. Pituitary apoplexy as another name, guys. Okay, so post-pituitary features of hypopituitarism, and along with that, there will be a lactation failure. Yes, also there can be what? Hypothyroidism. क्या हो सकता है, guys? Hypothyroidism. Plus, there can be a cortisol deficiency. There can be a cortisol deficiency. And these symptoms are depending upon the extent of the necrosis that has taken place. Depends upon extent of necrosis. Depends upon the extent of necrosis. Okay, depends upon the extent of necrosis. So what will be your treatment, guys? You have to substitute the hormones. Okay, the treatment will be substitute the hormones. Substitute the hormones. So guys, the patient after the PPH complaining of amenorrhea, patient after the PPH complaining of amenorrhea with the lactation failure, your diagnosis will be Sheehan syndrome. Patient after the PPH having secondary placental beds. Okay, after that she went to curettage, the amenorrhea is there, the cause is Asherman syndrome. So Sheehan and Asherman syndrome are very important, guys. Remember these two syndromes very well, along with the PCOD. Okay, a 30-year-old woman presents to your OPD with the complaints of foul-smelling discharge for the past 3 weeks. On examination, the discharge is thin, greenish white, and has a fishy odor on addition of the 10% KOH. What is the most likely cause? What is the most likely cause? So guys, what is your probable diagnosis? The diagnosis is bacterial vaginosis. The diagnosis is bacterial vaginosis. Okay, and this bacterial vaginosis is caused by Gardnerella. Okay, guys, let's discuss one by one these vaginites, all these three. If I talk about first one, guys, bacterial vaginosis. As you already know, guys, bacterial vaginosis is the most common vaginitis. Okay, caused by the Gardnerella. And we have one criteria in bacterial vaginosis called as Amsel's criteria. 3 out of 4 should be present over there. What are the 4 things, guys? Fishy odor, creamy discharge, clue cells positive, and whiff test positive. These are the 4 criteria of these are the 4 things in the Amsel's criteria following bacterial vaginosis. And the drug of choice will be, my dear students, metronidazole. Drug of choice will be metronidazole. So you have to remember these things. When you see fishy odor, creamy discharge, clue cells, whiff test, drug of choice is metronidazole. Most common vaginitis is bacterial vaginosis. Then the second one, guys, also you have trichomoniasis. Okay. It's caused by Trichomonas vaginalis. Okay, guys. There is a which type of vagina, guys? Strawberry. We have strawberry vagina. It's also known as, this strawberry vagina is also known as Colpites macularis. This is also known as Colpites macularis. This is also known as what, guys? Colpites macularis. After that, guys, in trichomoniasis, both partner is treated. There can be clue cells positive. In trichomoniasis also, there can be clue cells positive. And we have a greenish yellow discharge. Greenish yellow discharge. And drug of choice, guys, again metronidazole. And we have a strawberry vagina, guys, in Colpites macularis. Strawberry gums are seen in Wagner's granulomatosis, Sheehan ka. Then strawberry gallbladder you have, strawberry tongue you have in case of Kawasaki disease and scarlet fever. In Kawasaki disease, remember the treatment IVIG plus aspirin. Then aspirin has a side effect of Ray's syndrome. We'll not go that deeper, guys. Let's stick to the OB-GYN only. Okay, then the last one will have candidiasis. In candidiasis, my dear students, the cause is Candida albicans. Okay, and we have a curdy discharge. And the drug of choice here will be a oral fluconazole. The treatment will be a fluconazole, and the topical treatment will be cotrimazole. Okay, and as per the Suraksha Clinic, if they will give you an integrated question from the PSM point of view, that the woman is complaining of the vaginal discharge, as I have discussed in our PSM classes, that what will be your treatment, guys, in case of that? Which kit will be this? That will be kit green. Okay, because the kit green contains secnidazole and the fluconazole as a drugs. So in case of an vaginal discharge irrespective of the fully diagnosis, guys, because Suraksha Clinic gives a syndromic approach, the treatment based upon the symptoms, not on the diagnosis. So any complaining of vaginal discharge, doesn't matter it is frothy, doesn't matter it's creamy, doesn't matter it is green, whatever it is, vaginal discharge, you give which kit green with scnidazole and fluoroconazole. If the patient is complaining of anorectal discharge or the urethral discharge, you give kit gray. Patient complaining of PID, you give kit yellow. And patient, for example, having a genital ulcers, herpetic, okay, you give acyclovir kit red. Patient having inflamed lymph nodes or inguinal bubo, you give kit black. Okay, for that particular topic, guys, I'll be uploading the PSM rapid revision very soon, and you can go through my workbook as well. That is very important also. Okay. So guys, let's move to this vaginitis is called. So you already know the answer is Gardnerella. Next question, guys. A 28-year-old woman with a history of infertility for 3 years presents with a 6 weeks amenorrhea. She has a mild abdominal pain and spotting. Her UPT is weakly positive. On examination, she is hemodynamically stable. There is a 2.5 centimeter, 22.5 centimeter left-sided adnexal lesion. Ultrasound reveals a left-sided tubal gestational sac with no cardiac activity. Her beta HCG is 2500 international units. What is the best management option, guys? What is the best management option? Okay. The best management option, guys, patient is in the question, it's already mentioned, it's a diagnosis of ectopic pregnancy. Kya hai diagnosis, guys? Ectopic pregnancy. Okay, guys. Now, guys, the treatment of this ectopic pregnancy. What is the ectopic pregnancy? Pregnancy outside the uterus. So here, the most common site of, let me write, guys. This ectopic pregnancy is a very important chapter. 2 questions will come from ectopic pregnancy. Sure. Most common site is fallopian tube. Most common site is fallopian tube. If the question is most common in fallopian tube, then it's ampulla. Then it's ampulla. Okay, guys, then it's ampulla. Then the reasons of this ectopic pregnancy, a lot of reasons, guys. IUCD usage, PID, chlamydia, genital tuberculosis, and all. So let's discuss the main part, guys. That is a management part. The main part, that is a management part. If you have a ruptured ectopic pregnancy, guys, if we have a ruptured ectopic pregnancy, ruptured ectopic pregnancy. In case of a ruptured ectopic pregnancy, what will be the treatment, guys? You have to go for the surgery, salpingectomy. For ruptured, you have to go for salpingectomy. Okay. If unruptured, now if the tube is not ruptured, okay, that means if the patient would have been a ruptured ectopic pregnancy, he would have been hemodynamically unstable. But if the question is mentioning is hemodynamically stable, that we are suspecting it's a unruptured ectopic pregnancy. So there are 2 conditions, guys. Either we can go for medical management, either we can go for the surgical management in case of an ectopic pregnancy. But which one? Unruptured. If, guys, the adnexal size is less than 3.7 centimeter, you go with the medical management. If the beta HCG is less than 5000 international unit, you go with the medical management. If the size is more than 3.5 centimeter and HCG is more than 5000 international units, you go with the surgical management. Number one thing, what are the drugs you will use here, my dear students? The drugs in a medical management, you use the mifepristone, you use methotrexate as a main drug, you use KCL, and you use actinomycin. These are the 4 drugs that you use for the ectopic pregnancy medical management. But for the surgical management, if it is unruptured but the beta HCG levels are exceeding 5000 international units and the size is more than 3.5 centimeter. Now some are writing 3.8, some are writing 4. You remember more than 3.5 centimeter, guys. So you go with the surgical management. What are the surgical procedures? We go salpingostomy, and milking of tube, and also resection anastomosis. Okay, these are the main one. Then the differences between salpingotomy and gostomy, if we go deeper, in which we are applying the sutures and keep it open, not applying the sutures, you can refer to the main notes over there, guys. That will be too much. But for now, guys, the management part I'm discussing here, that is a very easy to crack now the question. You already know how to differentiate, guys. Now, the beta HCG are less than 5,000 and the mass is less than 2.5 3.5 centimeter. So guys, salpingectomy surgical procedures, you're not going, you'll directly go with the injection. Methotrexate is the mainstay of the treatment. Give injection methotrexate, guys. That's it. And then follow for the USG for the retained beds over there. So that is for ectopic pregnancy. So surgical and medical management. But if in case of, even if the beta HCG are 2500 and the size is 2.5 centimeter, but if question mentions it is a ruptured ectopic pregnancy, then no medical management, directly you have to go with salpingectomy. Directly आपको क्या mark करना है, guys? Salpingectomy. Is that okay? Now one more thing that I will add here is that how to diagnose this. So if the beta HCG is doubling in 48 hours, HCG is doubling in 48 hours, then doubling in 48 hours means it's an intrauterine pregnancy, and doubling in 5 to 7 days means it is a ectopic pregnancy. It's an ectopic pregnancy. And one more important thing about this is, guys, how to differentiate it is on this signs. If you have a double decidual sign, that is intrauterine pregnancy, and if there is no double decidual sign, that is a ectopic pregnancy. And this double decidual sign is because of the basalis and parietalis. Okay, guys, decidual basalis and parietalis. Let's move to the other question, guys. I hope speed is good enough and you are understanding and grabbing. Indication of cesarean hysterectomy or all except. So indication of the cesarean hysterectomy, in what conditions we go for the hysterectomy except placenta accreta. Yes, we go for the obstructive hysterectomy. Atonic uterus, yes, if there is a PPH, guys, if there is a PPH and it's uncontrolled postpartum hemorrhage, so the best treatment is hysterectomy. Ruptured uterus, guys, if the uterus is ruptured, we can go for the hysterectomy. But this covillier uterus, what do I mean by this covillier uterus? Let's discuss this. This covillier uterus, it's also called as bruised uterus. It's also called as bruised uterus. This bruised uterus, my dear students, it is seen in case of an abruptio placentae. It's seen in case of an abruptio placenta. What do I mean this abruptio placenta? It is a type of an antepartum hemorrhage. It's a type of an antepartum hemorrhage. What do I mean by now antepartum hemorrhage, guys? It's more than 28 weeks up till delivery. After 28 weeks till delivery, if there is a bleeding, we call it as antepartum hemorrhage. This antepartum hemorrhage, it can be, guys, it can be vasa previa, it can be placenta previa, or it can be abruptio placentae. Okay, guys. Now, guys, can we go for the hysterectomy in case of abruptio placentae? No. Let me tell you the management of this abruptio placenta, my dear students. So abruptio placenta patient coming with a painful bleeding. Okay, the presentation will be painful bleeding. Okay, the patient will present with a painful bleeding. The cause, most common causes for abruptio placenta is what, guys? It's increased blood pressure and trauma. That is why, guys, once there is a trauma and increased blood pressure, what happens due to this trauma? There is a bruised uterus. There is a bruised uterus. I can show you the image of this bruised uterus, guys. Maybe it's in our rapid file. Yes, this is a exact image of the bruised uterus, guys. Okay, covillier uterus. Okay, so what will be the management if the patient is coming with this bruised uterus or the diagnosis of an abruptio placenta, guys? You already know that you have to save the baby. Yes, so the management at that point will be, guys, normal vaginal delivery with artificial rupture of membranes. You have to deliver baby with the normal vaginal delivery, but you have to induce the labor with the rupture of membranes. What will happen once you go for a rupture of membranes, guys? The prostaglandins will be released and the induction of the labor will happen. Labor will be induced, number one thing. But, guys, the conditions when you have to go for a cesarean section only when fetal heart rate is less than 100 and fetal scalp pH is less than 7.2. At that time, if the question mentioning that the baby is going into the distress, then the treatment is cesarean section. But there is no indication of, guys, hysterectomy. There is no indication of hysterectomy in abruptio placenta. That is an antepartum hemorrhage. Okay. Now the first option is placenta accreta. What do I mean by this placenta accreta, guys? Let me discuss this also. It is a type of an adherent placenta. It is a type of a adherent placenta. What do I mean by adherent placenta, guys? When the neta bush layer is absent. Now, what do I mean by this neta bush layer? This is a fibrinoid layer, guys. This is a fibrinoid layer. If this is a placenta, it's a uterus, it's a placenta attached. So here there is a fibrinoid layer. Okay, this fibrinoid layer helps in the smooth separation of the placenta. Okay, but when this fibrinoid layer is absent, okay, guys, when this fibrinoid layer is absent, okay, so it will be difficult for a separation of the placenta, yes or no? So sometimes what happens once you're trying to forcibly to take the placenta out, what happens, it depending upon the degree of this adherent placenta, it can be increta, it can be accreta, or it can be parcreta. So depending upon the degree of this placenta, what happens, it can cause bleeding. Either it is connected to the myometrium, it's connecting to the serosa, or it's going deep down parcreta to the uterine muscles. Let me show you guys an image for that. Placenta accreta will be useful. Okay, guys, it's here. So it's normal, it's accreta, increta, and parcreta, guys. So the directly workbook image. Okay, so out of which of the following can cause a more complications? If the question will come out of which of the following can cause a more complications, so which type of adherent placenta it will be difficult to take out once that is going beyond the serosa to the uterine muscle, this one. So parcreta will have what? More chances of bleeding. Okay, and the treatment, guys, what will be the treatment? Laparotomy plus obstetric hysterectomy. Laparotomy plus obstetric hysterectomy. And if you can save the uterus. Followed by that, we can give drugs, actinomycin. We can give drugs, guys, actinomycin and methotrexate to control the persistence of the trophoblastic tissues. So this neta bush layer, what happens to this neta bush layer, guys? It helps in the smooth. It helps in the smooth separation of the placenta. It helps in the smooth separation of the placenta. Okay, what is the treatment, guys? Obstructive hysterectomy. It can be increta, accreta, or parcreta. It can be increta, it can be accreta, or it can be parcreta. Okay, so yes, that is also an indication of the hysterectomy. Rest, guys, other two options, atonic uterus, you already know, and rupture uterus. Okay, so there can be different types of the ruptures. It can be complete or incomplete depending upon the layers. Okay, if it's a complete rupture of the uterus, you can directly palpate the parts. Okay, if it's an incomplete, that means that some layers are still intact but the uterus is not fully ruptured. At that time, you can call it also as uterine dehiscence. That's the deeper part, guys, but you already have an idea about abruptio placenta and this adherent placentas. Next question, guys. A 32-year-old woman presents with a primary infertility. Okay, she has been trying to conceive over a year with unprotected intercourse but has not been successful. On further evaluation, her menstrual cycles are regular with a moderate flow and mild dysmenorrhea, and her partner's semen analysis is normal. A tubal patency test is ordered. Which of the following test is more appropriate in this scenario? So the investigation of choice to check the tubal patency is a hysterosalpingography. What is the answer, guys? Hysterosalpingography. Let's discuss the infertility. What do I mean by infertility, guys? Not able to conceive after 1 year of unprotected intercourse. Not able to conceive after 1 year of unprotected intercourse. Okay, now, guys, there can be male causes. What can be the male causes, guys? Male causes, it can be oligospermia or there can be azoospermia. Okay, oligospermia or azoospermia. Okay, also that if we go to the deeper into the causes, guys, for example, undescended testes is there. Undescended testes are there. Okay, Klinefelter syndrome is there. Okay, hypogonadism is there. Hypogonadism, or can be a pituitary defect. Depending, there can be the different male causes, pituitary defect, and in female causes, guys, there can be anovulatory factors. Female में क्या होगा, guys? There can be anovulatory factors, and there can be the tubal problems. There can be the tubal problems. Okay, and these are the more treatable ones, guys. And if to check these patency of the tubes, guys, we go for hysterosalpingography. Hysterosalpingography to check the patency of the tubes. Okay, infertility causes can also be endometriosis, है ना? It can be also other causes because I mentioned already. But guys, one thing, if more than this, you can also go for laparoscopy plus hysteroscopy. Okay, guys, to check more additions and anatomy of the tubes. Okay, because endometriosis can also cause what? The infertility. Why I'm mentioning endometriosis here? Because the investigation of choice for endometriosis is laparoscopy. Investigation of choice for endometriosis is laparoscopy. So these are the just bit information about an infertility chapter, guys, and go through the semen analysis WHO criteria. How much should be the morphology of the sperm, how much should be the motility of the sperm, how much should be the volume of the sperm. That's already even mentioned in my workbook, guys. Go through those things. That can be in an MCQ. And then IVF criteria, guys, I've already discussed in how to do with IVF, then how to store this extra embryos, and what can be the drugs that can be used, how to stimulate it with an FSH, all the process. A patient presents in the labor room, guys, again an important question. A patient presents in the labor room at term. Clinical pelvimetry is performed. She has an oval shaped pelvis with the antero-posterior diameter at the inlet more than the transverse diameter. On abdominal examination, there is subumbilical flattening and the fetal heart is auscultated on the flanks. The most likely kind of pelvis is, guys, the already hint that have been given here in the question is an oval shaped pelvis. What is the hint, guys? Oval shaped pelvis. If I talk about, guys, most common type of pelvis, the first one, if I discuss the gynecoid pelvis, the most gynecoid pelvis, if I discuss the first one, guys, the most common type of pelvis, the most common type of pelvis is gynecoid pelvis, and the shape is a rounded shape. There is rounded shape. Okay, if the second one, guys, I talk about android pelvis. If I talk about android pelvis, guys, that is a triangular pelvis or heart-shaped pelvis. The third one, if I talk about anthropoid pelvis, guys. If I talk about anthropoid pelvis, in case of an anthropoid pelvis, we have an oval shape pelvis. Okay, and the rarest one is the platyploid pelvis. In this platyploid pelvis, guys, mainly face presentation is there. Okay, it's a transversely oval. Okay, and this is the oval shape. Okay, guys, so these are the different pelvis. So rounded is gynecoid, and all the normal vaginal delivery, NVD, and safe pelvis is a gynecoid pelvis. It's a gynecoid pelvis. Now, the guys, about this oval shape pelvis, guys, remember, now I have discussed in my main class that occipito-posterior, 80% will convert to occipito-anterior, and they will be delivered normally. Okay, and if the occipito-posterior will remain occipito-posterior, what will happen, guys? We go with the face to pubis delivery. And this face to pubis delivery that I've discussed in my classes, face to pubis delivery, that happens in which pelvis, guys? Anthropoid pelvis. That happens in which pelvis? Anthropoid pelvis. And the last one, if this occipito-posterior is not turning into occipito anterior, and it gets stuck between them. We call it as deep transverse arrest, and deep transverse arrest takes place in the android pelvis. DTA. Let me deep transverse arrest takes place in the android pelvis. And anthropoid pelvis, we have phase 2 pubis delivery. Okay, guys, let's see it here from the main notes. Okay, so type of the pelvis is, guys, I mentioned clearly here, gynecoid is most common. Look at these 4 images and we go for the normal vaginal delivery. Platypoid is rare and face presentation is seen. Then android, triangular or the heart-shaped pelvis. We have a deep transverse arrest because it cannot be turned wholly to the occipito anterior and it gets stuck in between. That's why it's called as deep transverse arrest. Then the forceps we use for the delivery. And phase to pubis delivery, that is the second most common, is seen in anthropoid pelvis. That is seen in anthropoid pelvis. So you have to remember the shapes of the pelvis as well as the phase to pubis delivery is seen in which type of pelvis, and deep transverse arrest is seen in which type of pelvis, and face presentation. Guys, one question can be asked from this type of pelvis as it's very important. So rest for the main information, you can go through the notes. Okay. Next question. A 26-year-old history of 2 first trimester abortions following delivery of a preterm baby at 30 weeks due to the severe preeclampsia. She's an anxious and wants to be evaluated preconceptionally. So guys, she's having a recurrent abortions and she wants to be evaluated preconceptionally. Which of the following investigation you will advise? So guys, you already know that recurrent abortions, mainly we have a most common cause as antiphospholipid antibody syndrome. Okay, and what is the investigation you do over there, guys? Lupus anticoagulant. Lupus anticoagulant. If I talk about, guys, abortion, guys, if I talk about abortion, what is the first trimester cause? The first trimester, the cause is chromosomal. Pehla cause kya hai, guys? Chromosomal. Second trimester, if I talk about second trimester, the cause is anatomical. Second trimester, what are the common causes? Anatomical. What can be these anatomical causes, my dear students? Septate uterus, bicornate uterus. There can be an incompetent cervix. That means the cervix is less than 2.5 centimeters. So these all constitute in the anatomical causes. Then third trimester causes, it can be any maternal causes. For example, diabetes can be there, pregnancy-induced hypertension can be there, hypothyroidism can be there, celiac disease can be there, SLE can be there, malaria. A lot of causes can be in the third trimester. Okay, so it was the causes. So about after the abortion, guys, let me discuss third trimester. I already told you diabetes, hypertension and all. After that, guys, for this APLA, antiphospholipid antibody syndrome, let me tell you, guys, we have 2 types of thrombophilias. This antiphospholipid antibody syndrome is a type of a acquired thrombophilia. Acquired thrombophilia. The antibodies we have, the antiphospholipid antibodies we have. Remember these 2 antibodies, they can be even asked from the pathology point of view, guys. Anti-cardiolipin antibodies. Anti-cardiolipin antibodies or anti-beta-2 glycoprotein antibodies. Anti-beta-2 glycoprotein antibodies. And what is the treatment, guys? The treatment, you remember, low molecular weight heparin plus aspirin. Low molecular weight heparin plus aspirin. Okay, if I talk about this, guys, inherited one, if I talk about inherited thrombophilias, guys, we have which mutation? Factor 5 Leiden mutation. Factor 5 Leiden mutation. And we can have a prothrombin gene mutation. We can have a prothrombin gene mutation, or there can be the deficiency of protein C and protein S. Remember, protein C and S deficiency. So it's all about thrombophilias, acquired and inherited, and they can cause a recurrent abortions. Okay, so lupus anticoagulant is the answer, guys. Okay. Now, a middle-aged woman presents with dysmenorrhea, dyspareunia, and infertility. On per-vaginal examination, you note tender nodularity of the uterosacral ligaments adnexal mass, and fixed retroverted uterus. Which of the following is the most likely diagnosis? Guys, third to fourth decade, middle-aged woman, we had discussed. Repeated question, guys. Dysmenorrhea, dyspareunia, and infertility. And there is a nodularity of the uterosacral ligaments. The diagnosis is easy one, endometriosis. Middle-aged, dysmenorrhea. Rather than mentioning this nodularity of the uterosacral ligaments, they can ask powdered bone lesions are there. They can ask that chocolate cyst is there. Right? They can give a different things. Okay, so what will be your diagnosis, guys? Endometriosis. So diagnosis is endometriosis. Endometriosis. And endometriosis में drugs क्या थे, guys? Danazol, DMPA, GnRH analogs, है ना, guys? Even OCPs. And what was the main aim of the treatment, guys? You have to go for the atrophy of endometrium. And for the cyst, you have to go cystectomy. For the cyst, you have to go cystectomy. Remember, guys, my dear students, the additions that are there, you have to go for adhesiolysis. You have to go for adhesiolysis. So that was all about endometriosis. Now this option number A, adenomyosis, that is a best friend of endometriosis. Let's discuss here this adenomyosis. Okay? Let me tell you about this adenomyosis, because either they can ask endometriosis or adenomyosis. Okay, we're not gonna leave anything. All we have to do is get everything done and get this exam done, right? No matter what. So I'm helping way out in every way possible. So adenomyosis, guys. Okay. So adenomyosis, guys, it's also called as endometritis interna. It's also called as endometritis interna. Endometritis interna. That means endometrium within the uterus, your uterine muscle. Endometrium within the uterus. Hey guys, and the presentation of the patient will be mainly multiparous. But in case of endometriosis, she can be nulliparous as well. Right? So multiparous, that means the age will be more than 40 years mainly. But there it can be 25 to 35 mainly in endometriosis. Okay. The investigation of endometriosis, I've already told you. What is the investigation of choice? Laparoscopy. Investigation of choice kya, guys? Laparoscopy. And here investigation of choice, gold standard investigation of choice will be histopathology examination, HPE. Okay, the best treatment here will be a surgical treatment. You have to go for hysterectomy because the family is almost complete. She's multiparous and the treatment is hysterectomy. The treatment is hysterectomy. The classical symptoms that the patient will present of, the classical symptoms, please remember these classical symptoms. Patient will have menorrhagia. Patient will have menorrhagia. Patient will complaining of dysmenorrhea. Progressive dysmenorrhea will be there. Patient will have a dysmenorrhea. And guys, also patient will have uniformly enlarged uterus. Uniformly enlarged uterus. Guys, the same presentation will be of a fibroid case. If you have patient around, you will see the fibroid patient having fibroid. She will say, I'm having heavy bleeding with a lot of pain. That means menorrhagia. What is menorrhagia, guys? Excessive bleeding. And what is excessive bleeding? More than 80 ml. The normal is 35 ml. But when I talk about excessive bleeding, that is more than 80 ml, followed by dysmenorrhea. What is dysmenorrhea, guys? It's a pain during the menses. Okay, then we have a types of dysmenorrhea. We have primary dysmenorrhea, we have spasmodic dysmenorrhea, we have congestive dysmenorrhea, we have secondary dysmenorrhea. These are the other names. We have membranous dysmenorrhea. Okay, depending upon the time. Okay, depending upon the time. I will also discuss that part. Okay, then this uniformly enlarged uterus, guys, the first two symptoms will be directly having same in case of a fibroid. Okay, but how this fibroid will differentiate it from the adenomyosis? In case of an adenomyosis, there is a uniformly enlarged uterus. Okay, but in case of a fibroid, depending it's a submucosal, it's subserosal, or it's pedunculated, there will be non-uniformly enlarged uterus. So guys, this is the main part here. So uniformly enlarged uterus you see in which condition? Adenomyosis. But if there is a non-uniformly enlarged uterus with the following symptom, your diagnosis will be fibroids. Your diagnosis will be fibroids. Then depending upon the location of the fibroids, it can be subserosal, it can be submucosal, it can be pedunculated. And that we'll see in the fibroid chapter. Okay. And on investigations, there are heteroechoic pattern. There is heteroechoic pattern with ill-defined areas. Ill-defined areas, and there are lakes of endometrial blood. Lakes of this hypoechoic pattern, ill-defined areas are called lakes of endometrial blood. That is seen in which condition, guys? Adenomyosis. That is seen in adenomyosis. Chain of lakes appearance is seen in, guys, this lakes. Chain of lakes is seen in chronic pancreatitis. That is a different chronic pancreatitis, है ना? And this lakes of endometrial blood, adenomyosis. And on the uterine biopsy, once we go for this biopsy, on the uterine biopsy, in case of an adenomyosis, my dear students, there are endometrial glands. There are endometrial glands within the uterine muscle. Within uterine muscle. Okay, so this was all about adenomyosis, endometriosis, adenomyosis. Clear, guys? So let's move to the next question. A 58-year-old multiparous lady presents to the gynecology clinic with the complaints of mass descending per vaginum. On examination, you note that the external os lies at the level of introitus. What is the degree of prolapse? What is the degree of prolapse? So let's discuss the prolapse, guys. What is the degree of prolapse? So you already know, guys, it's more prone to the elderly woman. Okay, and once the prolapse happen, okay, there are two features. Either it will involve the bladder, okay, uterus, it will involve the bladder, as well as it will involve the rectum, है ना, guys? So bladder जब involve होगा, once the bladder is involved, we have a features of a cystocele, and when the rectum is involved, we have a features of the rectocele. We have a features of the rectocele. We'll discuss first a prolapse, then by the Shaw's classification, what are the degree of the prolapse? That is about 1 minute game. Okay, so let me tell you about the prolapse mainly first. Okay, so there is a cystocele and a rectocele. So the first management, always, if the question will mention, my dear students, if the question will mention what will be the first management, so you will give the pessary ring so that she will have an ease in micturition and defecation. Okay, pessary ring. After that, guys, you have to tighten this anterior wall as well as posterior wall. So for the anterior wall, to tighten the bladder, you go for the anterior colporaphy. क्या करोगे आप मैनेजमेंट में, my dear students? You go for anterior colporaphy. And for the rectocele, you go for the posterior colporaphy. You go for the posterior colporaphy. Now, in order to just go concise with this option, guys, they will mention elderly coming to you with the complaints of or with the diagnosis of the prolapse. What will be your management? Your management will be what, guys? For elderly, क्या करोगे? For elderly, you will go with the hysterectomy. You will go with the hysterectomy plus pelvic floor repair. What do I mean by this pelvic floor repair? This is anterior colporaphy plus posterior colporaphy. This is also known as Ward and Mayo operation. क्या बोलते हैं दूसरा नाम, guys? Ward and Mayo operation. ठीक है? So that was for the elderly. If you are having a young woman, you will go with the Manchester repair. You will go with the Manchester repair or Fothergill repair. Okay, and if you have a nulliparous, okay, if you have a nulliparous, you will go with the sling surgeries. For example, you will go with the Shirodkar, you will go with Khanna's, you will go with Purendra sling surgery. So guys, these are all the sling surgeries. In young women, Manchester repair and Fothergill. Then go deeper into your note, guys. Discuss that in what condition we tighten them with the bilateral Macron-Rods ligament. The main goal is you have to tighten the anterior and the posterior wall to decrease the symptoms of rectocele and cystocele. Okay, but in elderly, we also go for, guys, Leaford's repair. Okay, just remember the names only. You don't have to go deeper into that, but at least remember elderly mein what are the names, young mein what are the names, and nulliparous mein sling surgeries. Is that clear? Now, guys, the classification, if I talk about, The classification, if I talk about the answer to this, if it is at the level of introitus, if it is at the level of introitus, guys, it is the third degree. Sorry, it is a second degree. If I talk about the level of introitus, guys, it is the second degree. So let me show you from the image point of view. Let me discuss this image here only. Okay. So guys, first degree level of introitus, guys, primary when it descends of the cervix in the vagina, guys. If at the to the introitus, it's second degree. If outside the introitus, it's third degree. And procedentia, all of the uterus goes out. So first, second, and third. At the level of introitus, it is second degree. Okay. Then outside the introitus, it's third. When the all uterus comes out, it is procedentia. So this is the classification called as Shaw's classification. Then I've already told you guys, it will involve the anterior and the posterior wall having the cystocele and a rectocele. है ना guys? Cystocele and a rectocele. And the treatment I've already told you, hysterectomy plus anterior colporrhaphy or posterior colporrhaphy. That's what we call what? That's what we call pelvic floor repair or Ward and Mayo's operation. Is that clear, guys? Yes, that is a clear. It's a recording lecture. Then the next question, guys. The next question, a 20-year-old girl presents to you with a cramping abdominal pain. It starts at the onset of menses and it's more pronounced on the first day. It starts on the onset of the menses and it's more pronounced on the first day of the menses. This pain started around the 15 years of age. That means when she's starting having menses. Which condition is likely to be suffering from? Okay, guys, this is a case of dysmenorrhea. Okay, so we have a types of dysmenorrhea. Let's discuss the types. The congestive dysmenorrhea, guys, the another name is secondary dysmenorrhea. Secondary dysmenorrhea. The spasmodic dysmenorrhea, the another name is primary dysmenorrhea. The another name is primary dysmenorrhea. Okay, guys. So as endometriosis, adenomyosis, we have already been through this. So let's discuss first of all these types of dysmenorrheas. So first, guys, if I talk about a primary dysmenorrhea, primary dysmenorrhea. This is also called as spasmodic dysmenorrhea. This is also called as spasmodic dysmenorrhea. This is also called as spasmodic dysmenorrhea. Guys, what do I mean by this primary or spasmodic dysmenorrhea? The pain starts 30 minutes before the onset of periods. Pain starts 30 minutes before the onset of periods. Okay. Then if I talk about secondary or congestive dysmenorrhea, if I talk about secondary or congestive dysmenorrhea, by that I mean pain starts 3 to 4 days. Pain starts 3 to 4 days prior menses. Pain starts 3 to 4 days prior menses, and it will remain throughout the cycle. That is called as secondary dysmenorrhea, guys. Okay, if there is a pain during the ovulation, that means on the 15th day of the cycle, guys, if there is a pain during the ovulation, we call it as mid-cycle pain or Mitchell-Marsh pain. What do we call it? Mid-cycle pain or Mitchell-Marsh pain. We call it as mid-cycle pain or Mitchell-Marsh pain. Guys, what is the reason behind this? Because the debris, the blood, it gets accumulated in the pouch of Douglas. Okay, and causes a pain called as mid-cycle pain. We have one more type of pain called as membranous dysmenorrhea. Okay, membranous dysmenorrhea. What do I mean by this membranous dysmenorrhea, guys? There is an absence of the fibrinolytic system. Absence of fibrinolytic system. Okay, once there is an absence of this fibrinolytic system, guys, there is a more clumping of blood. And once there are more clumping of blood, you need more contractions. You need more contractions. And once there are more contractions, there will be more pain. So that type of dysmenorrhea is called as membranous dysmenorrhea, because eventually if there is a fibrinolytic system, guys, once there are menses, there is a less clumping of blood, and this less clumping of blood, there will be no contractions needed. Even if the contractions are needed, that are very less. That is why the patient is having a less pain. But when this fibrinolytic system is absent, what will happen? There are more clots, and when there are more clots, you need more contractions. Eventually there is more pain. Such type of dysmenorrhea is called as membranous dysmenorrhea, guys. The treatment you already know, guys. Naproxen, NSAIDs. It can be naproxen, it can be ibuprofen, and usually you guys used to use mefenamic acid, meftalspas, but it's banned now by the drug associations. It's banned now. Meftalspas, mefenamic acid, we don't use anymore. And also we use OCP, so we can go for the ablation. We can go with the GNRH analogs, but they will cause irregular periods. Okay, so mainstay of the treatment are NSAIDs. So that was all about dysmenorrhea. Okay, guys. So that is about the part 1. So revise this much of part 1. Go with the main notes from the workbook, guys. So I'll be uploading the part 2 in the next coming 2 days. All the best. Keep studying. Okay, guys. And solve the questions on the channel FMG with Dr. Talib Bilal. And revise as much as you can. All the best and get it done. Thank you. I'll see you in the part 2.